So I'm Colleen Cebulla. I'm from Ohio State University, the ocular oncologist there, and I just want to thank Dr. Singh for hosting this wonderful meeting and the Ocular Melanoma Foundation as well. This is a really important event, and I'm really happy to be part of it. So I'm going to just talk about some of the screening. So this is typically what I order for a new patient with ocular melanoma. The initial screen is just like what Dr. Singh mentioned. We do an initial CAT scan of the chest, abdomen, and pelvis. In discussion with our medical oncologist, Dr. Olenki, he likes to get an initial MRI of the brain because very rarely there can be sometimes something we find in the brain. So we will start with this workup. And we also do some labs to get basic general assessment of the liver function test, general chemistries, lactate dehydrogenase, and complete blood count. But typically the follow-up is done by Dr. Olenki. So he's one of the melanoma medical oncologists who really cares a lot about uveal melanoma and kind of is one of our main specialists following uveal melanoma patients. So his general protocol for most patients is he does typically use a chest x-ray, I guess, every 6 months to look. And then typically the main test, like Dr. Singh mentioned, is really to focus on the liver. So he has switched in about the last year or two to doing an MRI of the liver, so MRI of the abdomen, but without any contrast. So it's done without the gadolinium. And that has some advantages I'll talk about in a second. And then he also he loves labs, so he does some labs too. So what's our rationale? So the metastatic workup, that Dr. Singh mentioned, this is standard of care. We all do this right off the bat. One reason that's important is that 10% of patients with ocular melanoma will have another cancer somewhere, so often we can detect that. And it's really important, of course, to rule out metastatic disease from the ocular melanoma itself. And again, it's just an important to get the overall staging of the patient. Where is the disease of that cancer? So in terms of why we do an initial CAT scan, basically Dr. Olenki says that it's very user-friendly for the oncologist, so he doesn't recommend starting out with an MRI right away. This is just a very good screening test, like Dr. Singh mentioned. But why has he switched now to doing this non-contrast MRI of the liver? So one reason is that MRI is more sensitive than CAT scan and also than PET scan. In his experience as a melanoma medical oncologist, he says that actually 10 to 15% of melanomas are negative on PET scans. So that's why he's really not a big fan of PET scanning. In terms of MRI, it has the benefit of not having any radiation associated with it. So that's another big advantage. Why don't we use contrast? Well, part of that is a lot cheaper without the contrast. It's maybe about 1/5 the cost. And in terms of side effects, you're not going to have any side effect from the dye when you don't use the dye. But without the contrast, the scan is still pretty sensitive for detecting any tumor because melanoma is typically bright on one of the scans called the T1 scan. So it's pretty sensitive at detecting it even without the contrast. If he finds a scan that looks abnormal, then automatically people will get the scan with the contrast to see if that helps clarify the issue. And typically our surgical oncologist will also look at the scan to see how suspicious it really is. So what's our rationale for doing screening at all? We feel that there are some better treatment options available if we can detect metastasis early. And especially that's true if there is liver-only disease. We found a couple options have worked very well for our patients. One option is known as hepatic resection. So if there's a solitary lesion that's in a good spot, sometimes that can just be removed by the oncologist. We have some patients who have been very long survivors going through that technique. So we think that is very helpful. And another very exciting technique for treatment of liver disease is something called localized melphalan hepatic perfusion. So what that means is delivering the melphalan chemotherapy specifically to the liver. And that has actually been very exciting. Dr. Olenki has mentioned that in his analysis of our results, there hasn't been any recurrent disease in the liver or other places systemically in our small series that we have. And then another center, Dr. Ping Pank at University of Pittsburgh, is also doing this procedure, and he's found similarly very consistent results with this. So this is something that's very exciting for the future, I think. And there's an upcoming study called the DELCATH study that we'll be participating in with other centers that will look at kind of this type of procedure. There are a lot of other options. They're a little bit less clear in terms of how useful they will be. Hopefully they will prove to be useful. Certainly clinical trials are very important. We want to enroll patients in clinical trials. And I think in terms of patient preference, I think that's an important consideration. A lot of patients do feel that they would like to have some sort of screening by the medical oncologist. The people who don't want to be screened, they of course opt out of it. But that's basically our rationale for why we screen and how they screen. So thank you.